Yeah, so hello everyone. My name is Jan Magielski. I'm Vice President for External Events at the Neuroscience Society, and our today's guest is Dr. Chen. Dr. Chen is an attending neurosurgeon and Associate Director of the Trauma Center at CHOP. Welcome, and we are looking forward to having you tonight.
Thanks. So do you want me to go through the questions first that you had started, or go through like the typical cases that I do?
Yeah, so we can start with the questions we prepared for you, and then you can move on to cases if that works for you.
Okay. So all right, so for the first question, what made you realize you want to pursue medicine? Um, I honestly can't really remember because I essentially have always wanted to be a doctor ever since I was as young as I could remember. And so I just really stubborn and never really changed my mind. But I had like a pretty significant medical issue. My appendix ruptured when I was 12. I spent 2 months in the hospital, and everyone said, after this, how could you still want to be a doctor? And so, but it actually just made me want to be a doctor more. So I studied neuroscience actually as an undergrad, where I went to undergrad at University of Florida. I there's like too many people who wanted to go into pre-med, so they in a pre-med major, they ended up having a microbiology major. Maybe you could actually get a job as a microbiologist if you didn't go into medicine. So there was also like almost like a create your own major type thing. So that was a neuroscience major, and then that's how I got interested in neuroscience. So that was from undergrad to med school. In med school, I would say that the neuroanatomy class I was really interested in, and the type of person that I am. So I get a lot of, well, I'm deciding between neurosurgery and neurology. To be honest, if you're deciding between a medicine and a surgery type thing, you're not a surgeon. Like it just, you don't really decide between medicine, like neurology and surgery. You decide between different surgical subspecialties. Um, so in in med school, I um, really liked neuroanatomy. I really liked, let me think, what other stuff? I guess just surgery in general. Although I wasn't like a super huge fan of just like general surgery or that kind of stuff. But I remember, being on my psychiatry rotation, and I was like, I don't think I could sit there and talk to someone for like 2 hours. Like I just literally am like a fly on the wall right now, and I couldn't do this. And so how would you describe each of the steps? So after med school, you get into like what you want to do, and now it's not, you just go directly into neurosurgery. Like we used to have a year of transitional like general surgery, and then you get just random general surgeon stuff, and then a little bit of neurosurgery. So now it's like specifically geared toward neurosurgery. So you have to do neurology, you have to do all these rotations in like the neuro-based sciences, and you really don't get any of the plastic surgery or the transplant surgery, and just kind of random surgeries that you're never going to use again, but you can say, oh, back in the day, I did this, that kind of stuff is not really that useful, to be honest. And then from residency, you decide at least halfway through probably what you want to do. Nowadays, neurosurgery is so specialized that you really either become like a neurosurgeon as a specialist neurosurgeon rather than like a general neurosurgeon. And so you go into vascular, or you go into tumors, you go into spine. You typically do kind of a handshake fellowship, in which is not ACGM accredited. The only one that is pediatrics. And so honestly, I went into residency not wanting to go into peds, but then I ended up going into peds. Peds at that point was still something that I felt like you could do a little bit of everything and you didn't have to go into this super subspecialized area. Although that's really changing now because, you know, especially at an institution like CHOP, you kind of have to be subspecialized or else you just aren't as good at your job. Um, I chose, so then after that, so I chose to go into pediatrics. That's a year fellowship. Typically fellowships are a year, endovascular is 2 years. And then after a fellowship, you become, you know, an attending and get a real job after, you know, like 40 years. So, and I chose neurosurgery over the other specialties. Again, I kind of touch upon that because it was never about medicine versus surgery. It was just kind of like what type of surgery I was going to do. I used to think that I wanted to do trauma surgery, which to a med student sounds like super cool and interesting. But honestly, like trauma is just something that like nobody wants to deal with once you actually do it. So I was actually thinking about like trauma surgery, plastic surgery, and decided that this neurosurgery was just way cooler because we really don't know the brain at all. I say, what do you do on a daily basis? How much time do you see? Okay, so I have a very skewed view of pediatric neurosurgery. So I work at an institution that sees zebras and not horses. And I'm very, very busy. All my partners are very busy. So most pediatric academic institutions really just do 1 or 2 cases a week, maybe that, you know, all the really hard cases typically come to a tertiary center like CHOP. And so nobody at CHOP can be like, oh, I don't want it and I'm going to send it somewhere else. So we're essentially the, you know, the end of the train track, if you will. And so therefore, my days are not necessarily planned out very well because I could have an add-on case from someone who needs a surgery from before. I could have like a post-op complication and then I need to go to surgery. So I typically have 2 block times a week of surgery. Having said that, I typically do operate most every day just because either I'm helping my partner do something, there's too many cases to get, there's too many cases to cover, or I'm getting like an old patient that needs a surgery, and you know, if I'm here, I'm going to do it. So even though I may have like a random day where I'm like, oh, I don't have anything tomorrow, I can do a research project, I don't necessarily count on that I'm always going to have free time. That's not necessarily everyone's job because, again, it's because this institution is so busy that I just kind of get used to it. And so I do clinic 1 day a week. I'm supposed to operate 1 to 2 days a week block time, but that actually is very variable depending on randomly if someone comes in and needs an operation. And when you're on call, which we take 1 week a call at a time, then it could just be like you're just operating nonstop. I do research. We have to do research to be promoted at Penn. I am CE track, which means nothing to anybody except for Penn decided to be very difficult in terms of being promoted. And so Penn and Harvard are the 2 institutions that are the most difficult to be promoted. CE track means that I have to do like, I have to publish or perish basically. AC track is that you just really have to do kind of clinical stuff and you don't have to publish anything. But in general, neurosurgery, because people have really big egos, have always been CE track or tenure track. And so it wasn't a choice basically when I started. So to give you some kind of understanding, I probably have between publications and abstracts have like over 140. I'm only an assistant professor and I'm a little bit worried whether or not I'm going to get promoted versus if I were in most other institutions beside Harvard, I would have been a full professor already. So that's Penn specific, but it's not, again, it's not necessarily everywhere you go. my old chairman at Penn I trained at Penn, but my old chairman at Penn used to say he would tell people not to go into pediatric neurosurgery because CHOP isn't a very it has a very skewed view of the world. So like we literally do everything everybody does, every case, and we get all these crazy cases, difficult cases, and we operate all the time. But in most pediatric centers, either the good cases may be going to the adult people who specialize that, like in vascular, or they just do like degenerative adult spine and shunts. Like that's what the real life is. So that's why he would tell people not to go into it, because you're not going to find a job like CHOP. So, which I don't necessarily think is completely the truth, but I do understand where he's coming from. All right, so having said that, I basically I get started about 5 o'clock in the morning. I still run like an hour every day. So my life is not completely unmanageable. I have 3 kids. My husband is also a neurosurgeon at Penn. So we're very busy, but I'm still like, my head's still above water most days. So it's doable. So, I give a lot of, women in neurosurgery talk. I give a lot of like, neurosurgery and, lifestyle talk, and it's not easy. And would I do it again? Yeah, we always talk about, joke around, like if I won the lottery, I still come into work, because what else am I going to do all day? I, it's something that is like a very weird job, because literally every day you come into work, you could like maim or kill someone, right? But it's also very rewarding, but it's also, very difficult, especially when you're here and then you have to worry about like the kids getting picked up, or you just have to have a really strong support system in everything that you do, because you can't be in all places at once. Okay, I think that may be all I have for there before we go on to other stuff. So people are asking, have you ever faced as a woman in a male-dominated field like neurosurgery? That's a great question. I sit on a lot of female in neurosurgery panels, not because I want to, but because people just like ask me to, because I'm a female. But so I'm actually in Pittsburgh right now giving a talk, and I gave this talk, and like, I don't try to be funny, but it comes out kind of funny. And one person came up to me after the talk and said that you're funny because you're real. And I was like, I am real. Like no, I'm just kidding. But so I think that I don't see myself as female, whether or not that's good or bad. Like, I'm very girly. I like to dress in dresses. I like earrings. I like eyelashes. Like, it's not that I'm like a tomboy, but I also just don't use my femaleness to my advantage or disadvantage. Like, some people might be like, okay, well, I'm going to get more out of this. So I'm going to be like, but I'm female, so give me more. But like, I never think like that, maybe because like, my mom was a tiger mom, but I also don't use it to a disadvantage, because I think I can do everything my male, counterparts can do. And so, but that's also kudos to my like partners, in that I'm actually, out of however many people we have now, which is like 8, I think. It used to be 3, and I was like one of the 3, and it's like crazy how our division has grown. But I am the only non white male. And so I said that to one of my colleagues one time in the ICU, and he's like, oh my God, I never realized that. And I think it's just because like people just know me as me, and like they don't see me as anything different, because again, I don't use this to my advantage or to my disadvantage. So people don't really realize that. But it's also like I said, a kudos to my partner, who never treats me any differently. Like, I'm just one of the boys. Like, I don't get offended if they talk about stuff. They'll never they'll never look down upon me. If anything, they think that they don't know how I can juggle everything, because they wouldn't be able to, like in my life. And then when I sat on a panel one time, talking to other female neurosurgeons like around the country, it was very interesting to get their perspective, because one of them said, no, your male counterpart should be like, oh, this is, Dr. Chen, and she's my partner. She's not, someone who, like, she's my equal, and they need to like emphasize that more. And I'm like, I don't know that I've ever actually needed them to emphasize, because I feel like I don't need someone else to tell me that I'm badass. Do you know what I mean? Like, it just, I am who I am. If you can't accept it, like, then go somewhere else. Like, I'm not going to apologize for me being what I am. Like, I'm not, like, again, not going to use it to my advantage or disadvantage. Do you want to go to other questions first, or I'll like do a little bit of a presentation that
Yeah,
I had for the Cornfield
yeah.
Society?
One other question was about your research. If you could elaborate what research you're doing besides operating, because you mentioned
Oh, I do
that you.
mostly
Oh,
clinical. Okay, I do mostly clinical research. Having said that, people do have labs. My husband does have a lab at Penn. So you can do basic science research. It's really difficult if you don't have protected time, because like I said, the days that I try to dedicate to research, I may end up operating. So I do do a lot of research in TBI. I do a lot of research in like non-invasive, like neuromonitoring, that ties along with TBI, with basically anything neurosurgery that is could be hypertension and that type thing. And then, sorry, it says my internet connection is unstable. Can you hear me?
yeah, we can hear
Am I
you.
hearing? And then the other research I do, because most of my clinical like areas are in vascular neurosurgery. So I also do clinical stuff in vascular neurosurgery. So that pretty much like in ICU type issues. So that's pretty much like what my research is focused in. But pure clinical, I don't have a basic science lab.
Oh, then there's a question in the chat. Could you explain what the ACGM is?
So that is the graduate medical education office. And so basically anything that is residency related goes through the ACGME. So all the work hours, all that kind of stuff. So, I mean, it doesn't really matter for the fellowship, but most fellowships, like if you do in spine, they're like, oh, you go to this guy or this girl who does a really like is well known in spine, and you just basically sign off like they did a year with me. But pediatrics is one of the only one that like has a separate board, like we have the American Board of Neurological Surgery, in which that's our board certification board, but we also have, and I'm also a PBNS approved, which is the American Pediatric Board of Neurosurgery. So it's just this like, I guess, more regimented, because we have to do a certain amount of cases. You can only pick from fellowships at pediatric hospitals that do more than 400 cases a year. So like all these things are much more regulated, because just like residency is super regulated, like the ACGME accredited fellowships are more regulated.
Yeah, I think for now it's all the questions. So if you want to move on to your clinical cases, then.
Okay, so I will start. Okay, I'll start here, I guess. Let me share screen. Okay. So this is, I don't know why that showed up. Sorry. So this is a talk I gave at the Cornfield Society, which I think is like a pediatric society of the Penn med students. And this is like an old drawing of a kid with hydrocephalus, which means too much water in the brain. And this is something that pediatric neurosurgeons deal with the most commonly. And so, for me, deciding between adult and peds was very easy, because I much rather do a shunt revision than like adult degenerative spine. So what I show here is, I didn't actually go through to see if the videos work, but I will try to kind of go through this. So shunts are basically a plastic piece of tubing that go into the brain that drain to some kind of orifice, typically into the abdomen, to relieve that pressure in the brain. But that leads to a lot of equipment hardware and infections, as you can probably surmise. So there's kind of this change in getting this back to like the endoscope. And so back in the early 1900s, Walter Dandy, which you guys may have heard about like in neuroscience classes, he sacrificed the optic nerve to treat aqueductal stenosis, which is a type of like hydrocephalus, too much water in the brain. But again, like these days, yeah, we can't do that. We can't make them blind to treat hydrocephalus. So this in the 90s, we kind of moved back to this ETV, which is trying to make a hole to drain it normally instead of doing a shunt. And so basically B is where you make a hole. So we stick the endoscope through the brain into the ventricle, and then we poke a hole here so that this mass here is a tumor and it's blocking the normal flow of hydrocephalus. And so here is a pre-op versus post-op, where you can see that these ventricles are too big because there's a web right here. I don't know if you can see like that line there. And so if we make a hole here, the fluid can travel in the front rather than in the back. And you can see this black jet flow of pre-op to post-op. So let me see if this will work. The video. Okay, so this is an endoscopic view. This is like a 4 millimeter or 2.7 millimeter endoscope. This is into the ventricles of the head. That's what produces the cerebral spinal fluid. That's what produces too much water on the brain if you have certain, pathologies. And so this is the optic nerve up here. This is the bowing of that third ventricle. This is us sticking a blunt object in, and then we're gonna enlarge it with a balloon here. And then so that's basically making that hole that I was talking about. This is a very common, more so in the peds population than the adult population, but this is a very common procedure that we do almost weekly at least. But the endoscopic ways, it's not just like an ETV. You can also do it in various other disorders. So right here, I can never stop it exactly at where I need to stop it, but that red thing down there is the basilar artery, and that's the artery that supplies the back of our brain. So we can't hit that, and it's always very close. So this is another film made by an old resident. I'm gonna move on. So this is again in the ventricle, and then we're going into the third ventricle, and this is actually a tumor. So a lot of times we biopsy tumors endoscopically, and so you can see that it's bleeding, but like this bleeding is literally is very, very small. So that's that hole we made, and you can see the pulsations of the hole. The tumor, when we can biopsy, then if it's something that's not supposed to be operated on, supposed to have radiation, then we can just go on to radiation with this very minimal, basically it's just, a small burr hole. Sometimes, like for instance, there's a tumor here. Sometimes the bleeding is too much, we can't see anything. But when we get a head CT, we literally don't see any bleeding at all, because the bleeding is just so magnified with the endoscope. So this is a 1-year-old with a very large tumor. This tumor is called a craniopharyngioma, and so we do endonasal surgery for this type of tumor. So we take this tumor out solely through the nose, and you can see how large this tumor is. It's mostly cystic. So these are the turbinates of the nose. And then this will fast forward. And then this is just like, we work in conjunction with provide access to it. This is the back of the sella, which is the bone right before going into the brain. And so this here is the opening of the dura, which is the covering over the brain, and all the white stuff, the clear stuff is cerebral spinal fluid coming out. So that is the optic nerve draped on top of this capsule of this tumor. So we kind of just have to, and that's all calcium. This is a capsule, but all that other stuff here is calcium. So we kind of just have to pull somewhat blindly to get this through the nose. We're one of the only institutions that does this through the nose. Most other institutions do it. And you see the artery there, like we can't take that. She's going to have a stroke. Do this through a craniotomy, but we've realized that we get a much better like overall results from not retracting on the brain by doing this endonasally. So you can see the optic nerve is super thin here. This is very calcified, so it's a very hard structure that we're trying to get through the nose that we can't rub up to the optic nerve because that would be bad. So this is all calcium coming out with this is tumor wall, and that's all just calcium. It's a big chunk of calcium, and I think I hit that optic nerve. All right, so this is the end of the video in which you can see from, instead of going from top down where we saw that previous endoscope from the ventricles down, now we can see the ventricles up. So those are the lateral ventricles up there, these two things, and then the third ventricle. So now we're seeing it through the nose, which is just crazy, right? So this is her post-op scan. So she has, no more tumor. Remember how big the tumor was before. This is another 3-year-old here, same thing. These do happen in like younger kids a lot of times. This is a 3-year-old post-op of endonasal. And then this is something that we don't do very often, but we can often now laser very deep structures instead of doing an open craniotomy for epilepsy surgery for tumors. And so it is what it sounds like. It's a laser into the brain. You press a button and it will give you a heat map about the damage it caused. And you can, cure tumors and or seizures with this type of technology. It's very minimally invasive, does not require any incisions except for just a stab incision of the probe. Other stuff that we commonly do, we do a bunch of fetal surgery. I don't do it, but we do a bunch of fetal surgery at CHOP. This is the uterus of the mom. This is the back of the baby who's only 25 weeks gestation. And this is their back being delivered so that as a team, we can close this back. This is a myelomeningocele, meaning that the spinal cord is on the outside of the spine. So when you close this prenatally around 24, 25 weeks of gestation, they do much better in terms of being able to move their lower extremities more so than if you wait till they're after they're born. So fetal surgery is a major surgery. Now this is what it looks like closed. And then this is what the whole uterus looks like, and then you close the uterus. Hold on, my internet connection is unstable again. Okay, am I back? Another common thing that I do a lot of is craniosynostosis surgery. That basically, in a nutshell, means that I have that the patient has closed the sutures of the head of the skull too early. So you can understand that there might be a disconnect between brain growth and skull not letting it grow. So they can run into a lot of issues that's neurologic and not just cosmetic. Obviously, this is cosmetic. Nobody wants a triangle on their forehead, but so we do that. There's also, other types of craniosynostosis. There's you can see the CT scan is showing that this side has no suture left. This side is normal. Then we have like crazy stuff where this poor kid is like, there's just no skull really. We don't see this that often, thank God, but we see it. And then lastly, if we get to these kids early, we can do a less invasive surgery, basically take the abnormal suture out. We place springs, you see how it goes from here, and then it's like an internal springs, and then their head shape gets better without us having to do like a whole reconstruction, which is what sometimes we literally take the entire skull off and put it back on. So that you can see atypical cases. This is a kid who has unicoronal synostosis. You can see that this side is normal. I know it looks abnormal, but actually that's the normal side. This side is the abnormal side. This suture is fused, this suture is open. So you can see the discrepancy in their eyes. We do a distractor, meaning that we put a distractor and then we turn it over the next few months. to get the head shape better. And then this is the kid post-op, so you can't even tell that anything's happened. And then we'll finish off with things that we'll only see a couple times in our lifetime. Conjoined twins. So these were conjoined twins at the head. These were conjoined twins at the spine. We use the same kind of technology that we did from these distractors that I was showing back here to separate them. We basically we can't just like cut them, right? Like they're sharing a sagittal sinus, they're going to bleed to death. They also need to grow new skin over it. So we use this kind of, specifically made for them technology to distract them more and more so that we, one, get more surface area of tissue and sinuses and everything like that for several months. And this is kind of what they look like. And then not only that, but so pre-distraction, you can see they're really close together. Now they're almost like not, in a triangle shape. This looks ridiculous, but it's actually tissue expanders, because you're trying to grow more tissue, because once you cut to separate them, you're not going to have any tissue to put, and now you're like staring at brain, like you can't do that. So this is over 10 months, this tissue expander. So this might actually leave you enough tissue to separate them. I don't want to get too much into that. This was just like a drawing of the twins. They did end up needing some reconstruction as your first birthday. And this is all like a team effort. This is the twins separated, together by the spinal cord. And again, the same thing here is tissue expanders. Like we have to think ahead. You can't just separate them and be like, oh, what's wrong with this gap? So this was them. I know they got real chubby. So this was them like at 8 months to separate. And this took general surgery because their rectum was together, us because their spine was together, plastic surgery separated the soft tissue in the skin. So this picture here, that's their spinal cord. It was shared, and it was actually kind of crazy because we would stimulate one side and then the other twin would kick. But then this is what they look like with, after the tissue expander, and they were able to close it primarily. Again, the first few, like that's kind of bread and butter for me. But I mean, I'd be remiss if I didn't, put that in there.
Great, thank you. So the one
all right, more questions. How do you practice new? Okay, how do you practice new forms of surgeries being developed or surgeries aiming to be more effective, less invasive? So my old chairman, I guess I quote him a lot, I should say this to him, is that residency only taught you how to learn. So yeah, you're gonna have to keep on adapting. You're gonna have to keep on like doing things less and less invasive. And so so my old chairman never touched an endoscope in his residency, even throughout most of his career. And then now he does almost all the pituitary surgeries. So you have to adapt and be able to either, if some of your colleagues know how to do it better, then like learn from them, or you have to, learn from you have to learn from yourself. You always have to adapt. You can't just be like, oh, well, this new technology, I'm not gonna like do with it because I'm just, a dinosaur or whatever. So a lot, in the old days, it was a lecture by one of my old attendings at CHOP said that, the person before him who's, he died maybe 5+ years ago, he was in his 90s. He said the switch from like open surgery to the microscope, he just couldn't do that switch. And so that's why he said he had to retire. And then for this person who was giving the speech, he said from the microscope to the endoscope, he couldn't make that transition. So he was like, it's time to retire. So for me, endoscope was something that I learned, in residency, did more as an attending, just as like, life progresses, you do more and more stuff. but whatever the next thing is, I don't know. But like either I'll have to die or I'll have to retire. Like that's kind of how it's gonna go. And so things like the laser, I don't know how to do the laser. It was not available when I was a resident. So I have to call upon my colleagues to like teach me a few times until I can do it on my own. So I think that was how I answered that question. And then how would you recommend finding a good mentor within neurosurgery? So a couple things. A good mentor should have your shared interests. So I wouldn't find, like for instance, me deciding what I wanted to go into. I like tumors. I like vascular. I do not like the congenital, like myelomeningocele stuff. So I would not find someone, obviously, who did that because I don't want to do that. So they have to have your shared interests. And then the other thing is, it's hard to know whether or not they're going to dedicate a lot of time to you, but um, that is by definition what a good mentor is. So even if you find someone who's like published a million papers and like is like the best in their field, but if they literally never talk to you, like they're not a mentor. So I would almost rather have like the more junior person who's going to talk to me, who may not know everything, but can at least teach me some of the mistakes that they made along the way or what they would have done differently, because you know that they're going to, actually mentor you.
Well, in terms of mistakes along the way, I was wondering what would you do differently if you were to like go through your path once again, if there's anything.
Mm, that's a good question. I don't really think regrets. I don't know that I would do anything differently. I'm pretty happy with where I ended up. I mean, residency is hard. Nobody's gonna like, fellowship is hard. Your first few years in attending while you're like doubting yourself about everything is very hard. But once you kind of get into the swing and stuff, you've established your reputation at your particular hospital. People think you're, good or competent at least. You can tailor your practice for the most part to what you want, no matter what you go into. Um, there's certain subspecialties like vascular, which you're going to take more call. Your call is going to be very hit or miss. You could be super busy depending on what institution you are, like as a vascular surgeon, but you can also have a life. So if you go into something like functional, you probably aren't going to do any non-elective cases because those are essentially all elective cases. And you can really probably be like very particular about how you set up your practice to have a lot of extra time. You can find a practice where you're kind of just in private practice. You can ship everything to the academic center. Now, again, I don't know if it seems like I'm bitter, but I can't like turn anything away. Like everyone comes to CHOP. So, but that's what I chose and that's what I want because that's the most interesting stuff to me. So I would never end up in private practice because then I want to do the cases I wanted to do and the research I wanted to do.
I see. And also, like circling back to the mentorship part, is it common for physicians at CHOP to have whether undergrads or med school students to assist with their research? Like how?
Yeah.
Because you mentioned you don't run a lab, but we were wondering how does it look like from the organizational standpoint.
Yeah, no, I mean, I would say probably weekly somebody reaches out to me via email I must be on some list somewhere because it's like overwhelmingly how many people reach out to me. Sometimes I say yes, sometimes I say no. It, clinical research always needs people to basically like do chart reviews and get, know how to write papers and that kind of stuff. So I've probably mentored like 30 to 40 people. I know I look young, but I'm not that young, but still just, doing data collection and doing like writing papers and that kind of stuff. So even if you're not like pipetting in the lab, there's still plenty of opportunities for people who do clinical research. What was your favorite part of med school and residency? None of it. No, I'm kidding. So med school, I think like, the camaraderie, because after med not anymore, which I understand. Like now looking back and I'm like, oh, I can't wait till I never have to study again, which is really not completely true because you're always kind of studying. But you don't really work in small groups anymore, right? Like you're more of an adult after med school. You're not going to have like the late night ragers, like studying with your colleagues. Like I kind of miss that. I kind of miss when we go into clinical rotations in med school and just being like, oh, guess what I saw today? Just being like super kind of virgin to med school and to be like, oh, that's super cool. But now I'm like, okay, I don't care if I ever see that again, that kind of thing. Residency. God, what do I miss about residency? So I guess there's some kind of safety net there with residency and even in fellowship. So like for me, it's different from medicine people, but for me as a surgeon, you you have to finish the case. You have to figure out either how to get all the tumor out and finish the case or abandon it and finish the case. But at some point, you're the person responsible for moving it along. As a resident, you always have that little safety net. Like you might think like you're the best surgeon ever, but like to be honest, like you're not the one that has to like figure out how to finalize the end of the surgery and then like call it quits. Like that's what I think is like very different about like your first big tumor as an attending versus as a resident, you're like, oh yeah, this is so cool. Like I can do this and that. But like figuring out how to get yourself out of it and not having someone there to like be like take over and then do it, that's actually kind of frightening as a surgeon when you're first starting out. So I don't know if it's a favorite part of residency. It's just a part that I'm like, the grass is always greener. Like when you're a kid, you're like, I can't wait to be an adult. I don't know if everyone's like that. I was like that. I was like, I can't wait to be an adult. And then I'm like, God, I got to pay bills and like all this stuff. Adulting's not great. So it's always grass is greener on the other side. And so I don't know that that's a favorite part of residency, but it's something that I do kind of miss, not having that responsibility.
So unless there are any other questions, maybe as a final question would be, what advice would you have to students who would be interested in pursuing a path similar to yours, or like what would you advise for people who face some moments of doubt or difficulty along the way?
So I think that, the best advice I can give is to realize your limitations and successes. So like, yeah, not everybody can be a neurosurgeon and that's okay. And but to push onto something that you're not very good at and then like you really struggle through is something that you really have to take a step back and look at yourself about whether or not that's really what you want to do. Right? Like if you're like, I see some residents are very good and they go through and they're good surgeons. Some people are very naturally talented surgeons and you're like, yeah, you know what, you picked the right field. Some people really struggle with it. And so no matter how much mentoring or how much books you can read, and no matter how book smart you are, sometimes people just cannot like translate that to a clinical realm. And so for me, like I may not be like the best like book smart person, but for some reason I have a very good intuition clinically. And so for me, this is not something that I think I'm bad at. I don't think I would get to the stage if I was, but just seeing so many residents from many different institutions come through, there's some residents who really struggle. And I think that, it's okay to be like, this isn't for me. So like one of our previous fellows, in the operating room, just not very good. And just clinically though, like I'm just like every decision I'd be like, what are you talking about? Like just I'm not really sure. But obviously got to fellowship, and then went on to become an attending and then realized as an attending he just wasn't good with his hands and just quit neurosurgery. But I'm like, it took you 40 years of your life to like realize that. Like you could have realized that in undergrad and saved you a lot of heartache, right? And so I think it's okay to do that. Again, there's some people who are very narcissistic and can't realize that about themselves, but for the most part, people know if you're struggling, right? Like for me, nothing in my life was really that much of a struggle. Like not that I'm saying that everything like was easy for me, but surgery was not difficult. Like my hands would work. Like some people, I'm just like, I don't think your hands work, right? Like I don't know if they actually see that their hands like just cannot do what they want them to do, right? But for me, like it always came a little bit easier. And like, but I could see that about myself. And when I give feedback to certain residents, I'm like, there's some kind of disconnect between me telling you what to do and then you doing it, right? Like, so I'll be like, do this here. And then they would be like, just could not process it to their hands. And that's a problem, like as a surgeon, you know what I mean? And so, you may not be like the, most talented, gifted surgeon, that kind of stuff. And that's okay. And that's, there's a lot of bad surgeons. I'm not saying that, but I'm saying like the overall, if you have to really, really work at something and you struggle through it, basically throughout it, then it may not be for you. I think that's the best like advice I can give. But if you something that is reading it comes more naturally. For instance, I could not read an AP government textbook. Like I cannot be a lawyer. And like that's okay, right? But for me, like biology came very easily, like, just clinical like scenarios came very easily for me. And so like I said, that's why I'm saying like I didn't really struggle through that. But if I forced myself to become a lawyer, I would not be a lawyer today because I just could not do it. And so despite what you want to do, you have to take a look to see if it's a really struggle to you. And like, if you like doing it, it's such a hard life to not be doing like you want to go every day and do what you want to do.
Yeah, thank you very much for this very honest and useful advice. I think everyone appreciates it. And yeah, and I think on this note, we will finish today. Thank you very much for coming. And I know your schedule is very busy, so we very much appreciate that you found an evening to present and talk to us. And yeah, we wish you all the best at the conference in Pittsburgh. And yeah, thank you very much.
All right, bye.
All right, thank you.